Welcome to Roadmap to Residency. Hello everyone, I am Aviraz. Welcome to our Club 250 Matchmaker sessions. We will be running through a question with you guys to help you on your journey to a 250. So here we have which of the following components of the cardiovascular system is most susceptible to the medication prescribed to this patient. So we have a 69-year-old man comes to the office due to a 6-month history of chest tightness when he walks uphill or climbs upstairs. The discomfort radiates to his throat and lasts 5 to 10 minutes before slowly subsiding. Medical history is significant for hyperlipidemia and type 2 diabetes mellitus. His father had coronary artery bypass surgery at age 60 and his mother suffered a stroke. Vital signs are normal. Cardiac examination reveals no murmurs or additional heart sounds. The patient is prescribed a medication that is metabolized to as nitrosothiols in the vascular smooth muscle cells, and he reports rapid and significant symptom relief. Which of the following components of the cardiovascular system is most susceptible to the medication prescribed to this patient? Cardiac muscle, large arteries, large veins, and free capillary sphincters. So we will come back to these questions, but first of all, we need to clear out some of the basics. So this is a question on cardiovascular pharmacology. So we will just revise the most important drugs of CVS pharmacology. So our patient has chronic stable angina. So let's first understand how angina actually happens. So angina is the significance, or angina is the byproduct of the imbalance between demand and supply, right? So if there is an increase in the heart rate, if there is increase in the contractility, or if there is increase in the wall stress, then that will lead to the myocardial oxygen demand, which would be more than the myocardial oxygen supply, because the coronary blood flow and the blood O2 carrying capacity will be not as much changed, as much compensating than that of the demand, due to some of the factors like hyperlipidemia, like thrombus, like atherosclerosis. So due to that, the myocardial oxygen supply will be diminished. And when there is increased myocardial oxygen demand and there is the imbalance, then that will lead to the development of angina. So we have some drugs like beta blockers, non-dihydropyridine calcium channel blockers. So these two drugs, they diminish the heart rate. Beta blockers diminish the heart rate, and CCBs diminish the heart rate, and these two drugs diminish the heart rate and decrease the contractility. Now the wall stress is determined by the preload and the afterload. The nitrates lead to vasodilation and will decrease the preload, and there is dihydropyridine calcium channel blockers, which will decrease the afterload, and consequently the wall stress will be decreased. And talking about the mechanism of action of vasodilators, we have calcium channel blockers, we have nitrates, and we have sildenafil. Now, the calcium channel blockers, how does it work? Is that these calcium channel blockers block the calcium channel. Now, when the calcium channel is blocked, then the calcium cannot enter the vascular smooth muscle cell. And when the calcium cannot enter the vascular smooth muscle cell, then that will lead to decrease in the contraction. You need calcium to contract, right? So if you do not have calcium, there will be no contraction. So this phenomenon is of the contraction side of the calcium channel blockers. Now, talking about the nitrates and nitrites, so nitrates are the nitrates that we are supplementing, the nitrates that we are administering is just the supplement of the nitric oxide in the body. So nitric oxide is produced from the arginine. So the arginine produces nitric oxide. So this nitric oxide travels in vascular muscle cell, and then it acts on the guanylyl cyclase to produce CGMP. Now this CGMP will lead to myosin light chain phosphorylation and dephosphorylation, and eventually relaxation. Now, these relaxation will dilate the smooth muscle cell, or will dilate the blood vessels. Now, this CGMP that is there will be metabolized by phosphodiesterase in GMP. So if by any means we can block this phosphodiesterase, then there will be increased concentration of CGMP, and there will be prolonged relaxation, and that is done by sildenafil. Okay. Now, so we have calcium channel blockers, we have nitrates, we have sildenafil. Next up, we have calcium channel blockers. So this influx into the heart muscles and vascular tissue muscles leads to vasoconstriction and contraction. Remember, more calcium, more constriction, and more contraction. Okay. Understood. Now, calcium channel blockers inhibit the L-type calcium channels. Now, this word is important. L-type calcium channels leading to vasodilation. So, this is so important that I will just highlight this. So, inhibits the L-type calcium channels in the heart muscle cells, and it will lead to vasodilation, decreased contractility, and reduced heart rate. So, it affects the or it provides advantage for the stable angina in three parameters. So decrease the heart rate, vasodilation, and decrease the contractility. So demand is decreased, supply is increased through calcium channel blockers. So next up, we have the uses of the calcium channel blockers. And then we have here dihydropyridines. They are used in hypertension, angina, and Raynaud phenomenon. Dihydropyridines mainly dilates the arteries, and nimodipine. Okay, nimodipine is used in case of subarachnoid hemorrhage, and it prevents the cerebral vasospasm. Nicardipine and clevidipine are hypertensive urgency, used in the hypertensive urgency or emergency, and some non-dihydropyridine calcium channel blockers are used in hypertension, angina, and atrial fibrillation or flutter. Adverse effects of calcium channel blockers include gingival hyperplasia, peripheral edema, flossing, dizziness, cardiac depression, hyperprolactinemia, and constipation. So the thing that you need to remember from this slide is peripheral edema, that is CCB causes peripheral edema, and verapamil causes hyperprolactinemia. Now these three bit of information are very, very important in regarding the adverse effect of the calcium channel blockers. So let's talk about now beta blockers and ACE inhibitors. Now the beta blockers here, they block the beta 1 receptor in the heart. Okay, now when these beta 1 receptors are blocked, then this will lead to the blockage of conversion of ATP to CAMP. And when this to ATP to CAMP is not formed, then CAMP dependent protein kinase is not formed, and this will lead to inhibition of ATP dependent calcium reuptake. Remember, if we do not let the calcium go inside the cell, then there will be decreased constriction and decreased contraction. There will be decreased number of calcium channels, and there will be decreased velocity of contraction. So we are decreasing the velocity of contraction, we are decreasing the heart rate, and we are decreasing the contraction at the same time with beta blockers. So this is how actually the beta blocker works. And now let's talk about the AC inhibitors. Now, AC inhibitors, you know about the RAS system. Okay, so angiotensinogen is converted to angiotensin 1 by the effect of renin, and then angiotensin 1 is converted to angiotensin 2 by the angiotensin converting enzyme. Now, the AC inhibitors just block this angiotensin converting enzyme. Now, let's see what happens if you block the angiotensin converting enzyme. Then the angiotensin 2 will not be formed. If angiotensin 2 will not be formed, angiotensin receptors will be dysfunctional, will not function in absence of angiotensin 2. And now there will be then vasodilation. Okay, there will be no vasoconstriction, there will be vasodilation, and there will be no aldosterone secretion. So with AC inhibitors, the blood vessels will dilate to improve the blood flow, and it will reduce the blood pressure. With beta blockers, the heart will beat more slowly with less force, and the blood vessels will dilate to improve the blood flow, that is, reduce the blood pressure. Next up, we have the angiotensin receptor blockers. Same, okay? Just remember, we are blocking here in AC inhibitors, and we will block here in angiotensin receptor blockers, okay? Now, this will decrease the blood pressure. It will lead to treat hypertension and heart failure. It usually into the sartan, valsartan, losartan, okay? And is taken orally. Now, again, we have come to our question here. So we have which of the following components of the cardiovascular system is most susceptible to the medication prescribed to this patient? So cardiac muscle, large arteries, large veins, precapillary sphincters, small arteries, and arterioles. So we have the patient has stable angina, chronic stable angina, and experienced rapid symptomatic relief following a receipt of nitrate. Pharmacological nitrates are metabolized to nitric oxide and S-nitrosothiols via mitochondrial aldehyde dehydrogenase within vascular smooth muscle cells. These compounds, in turn, activate the guanylate cyclase and promote the conversion of guanosine triphosphate to cyclic guanosine monophosphate, which leads to dephosphorylation of myosin light chains and causes vascular smooth muscle relaxation. Nitrates predominantly affect the large veins, where smooth muscle relaxation leads to venodilation and increased venous capacitance. So, cardiac venous return is reduced, leading to reduction in the left ventricular interstitial volume and pressure, and a consequent decrease in the left ventricular wall stress. Again, we have another question here. So, which of the following drugs is most likely responsible for rapid reperfusion in this patient? So, 45-year-old man is brought to a rural emergency department due to severe chest pain, sweating, and nausea. The symptoms began suddenly an hour ago. He has no significant medical history, and his father died at the age 50 after experiencing sudden onset chest pain. The patient smokes a pack of cigarettes daily, and he does not take any medication and has no known drug allergies. The examination shows normal heart sounds and breathe sounds. ECG shows sinus tachycardia with ST segment elevation into 3 AVF. The patient is having uh, heart attack. So medical management for the patient's acute condition is initiated, and after initial treatment, the chest pain decreases and a reperfusion complex ventricular arrhythmia emerges. The arrhythmia is asymptomatic and resolves spontaneously. Which of the following drugs is most likely responsible for rapid reperfusion in this patient? So which of the drug caused rapid reperfusion in this patient? Now, when there is rapid reperfusion, there will be arrhythmia. So what is the drug? Alteplase, apixaban, argatroban, aspirin, or heparin? So the patient has ST segment elevation, STMI, and following medical treatment experience symptomatic improvement and reperfusion related arrhythmia. That is most likely the result of fibrinolytic therapy. So fibrinolytic agents are indicated in STMI. You all know that. But the administration of these agents leads to the breakdown of fibrin clot, and there is rapid reperfusion of myocardial musculature. Okay, and some patients, and due to that, some patients develop a self-limiting reperfusion related arrhythmia, or also called as accelerated idioventricular rhythm. So in the fibrinolytic pathway, the tissue plasminogen activator is released by the endothelium and cleaves the plasminogen to form plasmin. Plasmin then acts to both degrade the individual fibrinogen and breaks down fibrin. Now, this concept we will learn in hematology again, but only for the brief overview. The breakdown of the fibrin clot leads to the elevated levels of fibrin split products in the blood, and the pharmacological fibrinolytic agents that are used clinically include streptokinase and recombinant forms of TPA. So here we have the fibrinolytic pathway. Plasminogen is converted to plasmin, and this plasmin will convert the fibrinogen to fibrinogen-related products, and this fibrinogen will form the fibrin clot. And again, this plasmin will dissolve the fibrin clot and form the fibrin split products, or D-dimer. Okay. Now, streptokinase, TPA or urokinase, they enhance the formation of plasmin, because plasmin degrades the clot, right? And some of the antiplatelet medications we have here, okay. So the CAMP just inhibits the, and then there is the clopidogrel, prasugrel, or ticlopyrin, which just inhibits the ADP receptor. And if there is inhibition of the ADP receptor, then there will be decreased formation of the fibrinogen. Okay, then there will decrease binding of the fibrinogen with the GP23BA receptor, and the efiximab, EPT-fibrate, and tirofiban, they just directly block the GP2B3A receptor. And we have aspirin. So aspirin blocks the COX enzyme. Okay, and then COX is needed to convert arachidonic acid to thromboxane A2. Why do we need thromboxane A2? Because thromboxane A2 will enhance the expression of GP2B3 receptor. So we have multiple sites like ADP receptor blocker, clopidogrel, most important drug, and then we have GP2B3 receptor blocker, efiximab, and then we have the aspirin, that is the COX inhibitor. So we have again one question again. Which of the following is the best alternate therapy for this patient? So a 64-year-old man comes to the office due to exertional chest pain over the last 6 months. He is a lifelong 1 pack per day cigarette smoker and has a history of type 2 diabetes mellitus and peripheral artery disease. The patient undergoes treadmill exercise testing and develops substernal chest pain on moderate exertion accompanied by ECG changes. He refuses invasive cardiac testing. The patient is started on low-dose aspirin therapy, but experiences shortness of breath and wheezing with medication. So aspirin had lead to to shortness of breath and wheezing. Now, what is the second line of treatment? Apixaban, cilostazol, clopidogrel, enoxaparin, eptifibatide, naproxen, or warfarin. So the patient's clinical history is associated with vestibular angina. So aspirin impairs the prostaglandin synthesis by reversely blocking the COX. So inhibition of COX in platelets prevents the synthesis of thromboxane A2, which is a potent stimulator of platelet aggregation and vasoconstriction. But some patients are unable to tolerate the aspirin due to the exacerbation of pre-existing respiratory symptoms like rhinitis or asthma, or develop the allergic reactions like urticaria, angioedema, or anaphylaxis. So in these patients, alternate antiplatelet therapy will be to use clopidogrel. Now, this clopidogrel blocks the P2Y12 component of ADP receptor. Remember, ADP receptor blocker on the platelet surface and prevents the platelet aggregation. Hope you enjoyed the video. We will again back in the next one. Thank you for watching.